Welcome to Think Like a Pancreas, the podcast, where our goal is to keep you informed, inspired, and a little entertained on all things diabetes. The information contained in this program is based on the experience and opinions of the Integrated Diabetes Services clinical team. Please discuss any changes to your treatment plan with your personal healthcare provider before implementing.
Welcome, everyone, to Think Like a Pancreas, the podcast. I'm Gary Scheiner, owner and clinical director of Integrated Diabetes Services and Type 1 now for 40 years, just hit my 40-year diaversary. Proud to be your host for the program today. The topic is Type 2 diabetes medications for people with Type 1 diabetes. You think about it, we've had insulin now for over 100 years, and it's still the only approved medication for the treatment of Type 1 diabetes. We do have Symlin, the amylin hormone analog, but that's coming off the market shortly because no one was using it. So we really just have insulin as approved treatment for Type 1. But when you think about it, blood sugar management is a multi-hormone process. In healthy people, there's a multitude of different hormones that are used to keep glucose levels within a normal range. So it really does beg the question of why we only have one hormone that we're using for Type 1 care. And keep in mind also that without production of the amylin hormone, is the case in people with Type 1, it creates a significant challenge for everybody to manage their weight, their appetite, their food intake, makes post-meal blood sugar control a major challenge. So this whole question about what's the deal? Why are we only using insulin in Type 1 care? And that's going to be the topic today. And we're going to hear from a diabetologist and also a member of the IDS clinical team, whose expertise includes the multidimensional management of diabetes, Dr. Paula Diab. So Paula, welcome. I think everybody'd like to hear more about you.
Thank you. Before I introduce myself, I have a feeling that I'm the first on this podcast since you received your fellowship for the ADCES. And we were just chatting before the recording started, and I said, congratulations. And in your normal, unassuming and humble way, you don't think it's a big deal, but it actually is a very big deal. And it's a remarkable achievement. So I just want to say congratulations.
Thank you for embarrassing me, Paula. I appreciate that.
No, but it's a testimony to a lifetime of dedication to diabetes, and it's very well deserved. So congratulations. So I'm as a diabetologist and a family physician, but I don't like to be boxed into that little box because I think doctors sometimes just are well known for writing scripts and sending people on their way in 10 minutes. And I think just like diabetes doesn't come in neat little boxes. I enjoy the creativity of finding different solutions for different people. I think that's a bit of what we're going to touch on today. And I think in order to do that, you need to understand the medication that you're working with in order to exercise that flexibility and that creativity. I got my basic degree in medicine, and then I was launched into the world in the middle of an HIV pandemic in a rural, underserved and under-resourced hospital. So every time someone complains to me that the insurance won't pay and they can't get access to medication, I always think back to those days and I think, well, life isn't actually that bad anymore. But yeah, then I completed my master's and a PhD and worked in the field of diabetes for about 20 years and more recently in the field of obesity management. And then about 2 years ago, decided to study further and qualified as a diabetes education specialist. But I think I've learned more from the IDS team than I ever have in the 20 years of working in clinical medicine and diabetes. And I think a couple of years ago, if you had asked me about this topic, I would have said to you, no, type 1 and type 2 are two very different diseases and you can't just mix and match the medications. But I think when you understand how the drugs work and what they do, that's when you can start to mix and match and be a bit more creative.
Yeah, Paula, you came to us several years ago with an interest in becoming a certified diabetes care and education specialist. And yes, not a lot of physicians are interested in that. And I was very impressed by your passion for the diabetes care field. And you did spend a lot of time with our team, and there was a lot of back and forth because clearly, as a physician, there's a lot we learned from you as well. You should also mention that you're a mom. You have 3 kids, right?
2. A son and a daughter.
It just seems like 3 sometimes because they got so many activities there.
It's like 23 sometimes.
Yeah. And you're in South Africa, so you're doing this from quite a distance as well. But you work with our integrated diabetes patients on weight management and keeping glucose managed during that weight management process, which is tricky. but you find a way to balance all of that.
Yep. Lots of balls in the air. I'm the chief clown.
Yeah. All right. So I mentioned before that glucose management is not a simple matter of insulin. When a healthy person, non-person doesn't have diabetes, they manage their glucose through a multitude of hormonal balances. Can you just kind of give us an overview of what that involves?
Sure. So I think when I'm explaining to my patients, what I generally say to them, I say, think of glucose as fuel for your body. So if you think of putting gas in your car, it's a similar sort of process. And the aim is to keep that glucose between about 70 and 125 milligrams per deciliter. And you want the glucose to be inside the cells and you want it to be stored. So again, going back to the analogy of the car, you don't want the gas sitting on the sidewalk. You want it actually in the engine. So it has to be the glucose has to be inside the cells. So the key players that are involved are the beta cells in your pancreas, which obviously produce insulin, and that's involved in the glucose uptake and storage. And then the alpha cells in the pancreas, which produce glucagon, and that stimulates glucose release from the liver. The liver is kind of your buffer that stores and releases glucose as it's needed. And then you've got your adipose tissue or your fat tissue. And then there are various other organs, your muscles, and in fact also the brain that comes into the whole mechanism, how it all works. And basically what happens is after a meal, the glucose gets pulled up into the muscles, and what's not being used is then sent off to the liver. It's stored. Glycogen is synthesized in the liver and it's stored. And in between meals, when you're not eating, then the body can then pull that stored form of glucose out of the liver and bring it back into a usable form. If that fasting state is prolonged, the body is able to use amino acids, which is proteins and various other substrates to produce glucose if necessary. But that's a topic for a whole nother podcast. And then there's other hormones and that sort of play a more supportive role, your incretin hormones in the gut, and they amplify the insulin release after meals, as well as adrenaline, cortisol, growth hormone, that all impact onto that whole story. It's kind of like the thermostat in your house. As soon as the pancreas turns on the cooling system, so as your temperature rises or as your blood sugar rises, the pancreas turns on this cooling system, and insulin then moves the glucose into the muscles and the fats in the liver, or to be stored or to be used. And then when you haven't eaten for a while, that temperature then starts to drop, and the pancreas then flips the switch to glucagon and tells the liver to release the stored glucose and to make new glucose to keep things more comfortable. And then there's, as I said, there's all the other gut hormones and that interact to sort of balance it out a little bit.
Yeah, I think about the car analogy, the insulin driving the glucose down, and that's accelerating the car. And the glucagon's like the brakes to slow down that drop and help maybe bring it back up again. But you mentioned there's a lot of other hormones involved as well. The amylin hormone, which is also secreted by the beta cells, helps to slow down the appearance of sugar in the bloodstream. It keeps food from digesting too quickly. It blunts appetite, so it plays an important role. The adrenal hormones cause the release of sugars into the bloodstream whenever we're under any form of stress. And that can be emotional stress, physical stress, any kind of stress that can occur. And that's where the brain gets involved, is causing the production of those stress hormones when the situation arises. And the gut hormones, which also regulate the movement of food through the digestive tract. So the appearance of the sugars is regulated to a large extent by other hormones. So, given that there are so many different hormones and systems involved in blood sugar regulation, and there are so many other medications that can help to manage those for people with type 2 diabetes, why are there so few available for those with type 1?
So I think there are many different reasons. I think one of the reasons is because of the primary difference between type 1 and type 2 diabetes. The primary problem in type 1 diabetes is that thermostat is not working, and there's a lack of insulin being produced, and so you can't bring the glucose down. And so you need to replace that insulin. You've got an insulin deficiency and you need to replace that insulin. Whereas in type 2, the key problem is to do with the sensitivity of your target organs. And there are multiple ways to encourage these organs to either become more sensitive or to utilize the glucose in a better way, or to accept the glucose in a better way. So I think that is the main reason, because of that underlying difference, in that you basically have to give insulin in type 1 diabetes. I think also what plays into it hugely is that the risk of diabetes ketoacidosis and hypoglycemia is a lot greater in type 1 diabetes than it is in type 2 diabetes. So you're very much focused on preventing those highs and lows, and there's less wiggle room, should I say. The type 1 population is much smaller than the type 2 population, probably about a 90-10% split. Worldwide. If you're looking at doing a trial or you're looking at marketing a drug that's going to be cost effective and have a big population to take it up, there just aren't the number of people in type 1 diabetes.
Yeah, so a lot of it comes down to dollars.
Absolutely.
The pharmaceutical companies want a return on their investment, and it is a huge investment to develop a drug, to test it, to submit it, to market it. It's a huge investment. And they don't always see the type 1 population as large enough to help them recoup that investment, unfortunately. And the government's not really helping at this point in that regard either. So we're counting on the free market system to dictate what drugs come to market. And if there were 10 times as many type 1s as there are, there'd probably be more medications, more treatments available than what we have.
But I think having said that, the way that we're currently doing it, where we are developing and marketing drugs for type 2 and then using them off-label in a type 1 situation, we kind of
Tell me more about that off-label. I want people to understand what that means.
So off-label basically, so any drug that's produced basically gets a package insert attached to it that tells you how you can use it, when you can use it, what dosage, what the side effects are, what the contraindications are. So in other words, when you absolutely can't use it, in which populations you can use it with what interactions it's got with other drugs. And although we doctors like to be quite creative, we actually are bound by those rules that come with each, and if you're using something off-label, it means that you're going outside of those boundaries that are prescribed in that package insert. So what is happening at the moment is people are using type 2 or drugs that are developed and marketed for type 2 diabetes in the type 1 population. And that's not always completely unsafe. And I'll explain, we can chat about that a little bit later, and which populations and who you want to give it to. But you do have to be careful for a number of different reasons.
Yeah, so off-label, it sounds like you're going against the established guidelines that the government at least has set for each drug.
Right.
I mean, can you go to jail for doing something like that? How risky is it?
Generally, if you explain to the patient and you document that you explain to the patient you're using it off-label, and certainly not in South Africa, I don't think anyone's gone to jail for it. I don't know about in the States.
We have a lot more lawyers here, unfortunately.
But yeah, I mean, basically it is just, we do it quite often with pregnant patients because it's very risky to run a trial in a pregnant patient on a drug that you're not sure of. But what tends to happen is people fall pregnant without really knowing that they're not meant to be taking a specific drug. And so by trial and error, we realize actually drug A can actually be used fairly safely in pregnancy. And that's kind of what's happening at the moment with a lot of these drugs being used in type 1 diabetes. And if you also think about how they work, you can sort of logically deduce, okay, this one will be safe in these circumstances and I can use that drug fairly safely.
Word from our sponsor. Byram Healthcare understands that managing diabetes isn't one size fits all. With a full range of CGMs, insulin pumps, and diabetes supplies from top brands, Byram makes it easy to get what you need, hassle-free, shipped right to your door. And Byram's team of experts helps navigate insurance so you can focus on living your best life. Ready for better diabetes care? Visit byramhealthcare.com/podcast or call 866-692-8024 and select option 3. And now, back to our program.
So pretty much anything that's been approved by the FDA for any indication, for any health state, any type of person, it can be also prescribed to someone else in an off-label fashion, as long as the physician or the prescriber explains the risks to the patient, and the patient's willing to accept those. And I guess that's documented somewhere, that it more or less protects you against legal action. What are some of the more common drugs or drug classes that are prescribed off-label to people with type 1 diabetes?
Yeah, so I think at the moment there's probably about 3 different classes of drugs that we're using on a fairly regular basis. The first one is, and I'll sort of briefly just go over each of them and then we can go into more detail in each one of them. But the first drug class is the biguanides, or the metformin or glucophage. It's been around for donkey's years. The second group is the SGLT2 inhibitors.
Wait. Donkey's years?
Is that not an American?
No, but I like it. I like that. I'm going to start using that term.
Donkey's years means a long time.
Okay, let's go with that. All right. You can take donkey's time to explain this if you want. Go right ahead. See, I'm already using that term.
The SGLT2 inhibitors, which act mainly on the kidneys and pull glucose out of the kidneys, and then the new kids on the block, which is the GLP-1 inhibitors that everyone's kind of got on board with. But if we go back to the metformin glucophage, it's basically what it does is improves insulin sensitivity. So in type 2 diabetes, your primary problem is that you've got insulin resistance. And so in other words, the gates of those cells are not opening and they're not allowing the glucose into the cells. This drug is absolutely essential for any type 2 diabetic, anyone with prediabetes, anyone with metabolic syndrome, because there is that basic underlying problem of insulin resistance. But what we're starting to see is this issue of double diabetes. And I want to flag that and then maybe just come back to it a bit later. But double diabetes basically just refers to a dual diagnosis of type 1 and type 2 diabetes. And we're starting to see a lot more people being diagnosed with, or a lot of people being diagnosed with both type 1 and type 2, but a lot more people who live with type 1 diabetes who have some degree of insulin resistance. Mm-hmm. Whether it's because they have a family history of diabetes, whether it's because we have sedentary lifestyles, whether it's because our population is becoming more overweight, and that's leading to this whole issue of insulin resistance. I'm not sure, but metformin becomes very useful there. And I was actually just having a look. There was actually a trial that they did called the removal trial, where they looked at the use of metformin in type 1 diabetes to reduce and looked at its effect on the arterial wall lining. So one of the main problems in type 2 diabetes is that you get atherosclerosis, which is a thickening and a plaque formation on the arterial walls. And that then leads to your strokes and heart attacks. And so if you can reduce that intimal thickening, you can very often reduce your risk. And they looked at the use of metformin in order to reduce this. It didn't reach the primary endpoint. In other words, the primary reason for what the trial was set up for. But it did have a small reduction in HbA1c, so your average glucose, a reduction in weight, a reduction in LDL, which is one of your cholesterol markers, a reduction in the amount of insulin used, and that kind of makes sense because you're making the body more insulin sensitive. And it also improved renal functioning to a certain extent.
I know that metformin is a very inexpensive medication
Absolutely.
Relative to most others. What are some of the potential side effects of using it?
There really aren't any. I mean, we've been using it for so long. A lot of people used to complain of some gastrointestinal side effects. They feel a bit of nausea or constipation or diarrhea. But now they have extended release forms and that people can take at nighttime. And quite honestly, I've got a handful of patients that still complain about those side effects on the XR format. As you say, it's exceptionally cheap because it's been around for donkey's years. And yeah, it's really very safe.
I can think of certain populations within the type 1 space who become insulin resistant. Maybe it's temporary, maybe it's not. During adolescence, we see teenagers' insulin needs skyrocket a lot of times. Certainly people who gain weight, anybody who's
in a family history of diabetes. Diabetes, and family history of cardiovascular disease.
Yeah. And if it makes the body more sensitive to insulin and it keeps the liver from overproducing glucose, it can keep blood sugars much more stable, and you require far less insulin to do it. Yep. So it makes sense for more people to be using it. All right. The second class you mentioned were the GLP-1 receptor agonists. That's one of the more popular meds now. I read recently that in the U.S., 6% of the entire population is already using one of these drugs, and it's growing. So tell us a little more about that.
So they're a very interesting class of drugs because one of the main problems with insulin a few years ago was people didn't like taking injections. Now you bring GLP-1s on the markets and no one's got a problem with injections anymore. They're all pretty happy.
And there's the rub. Insulin will tend to lead to some weight gain, but what do the GLP-1s do?
Weight loss.
Weight loss. Amazing what people will put themselves through to lose some weight.
Absolutely. It's
Sorry
amazing.
to interrupt. Go ahead.
As you say, what the other misconception about the GLP-1s is that they suppress your appetite. They don't suppress your appetite. They promote satiety. And it might sound like we're splitting hairs, but it's quite an important difference to make. They're not suppressing your appetite. So you sit down for your evening meal and you feel nauseous and you can't eat and, you don't eat anything for the whole day. All they're doing is they're allowing you to differentiate between what you need to eat and what you want to eat. So as soon as you've eaten the calories that you need to for the day or in a specific meal, that you then feel satisfied and you don't feel like you need to eat anymore. And I've had patients describing exactly that they sit down and they look at a big chocolate cake and they think, no, that chocolate cake looks great, but I actually don't need to eat it right now. I don't think I'll ever get there, even on the drug, looking at chocolate and not wanting to eat it. Yeah, so that's one of their main mechanisms of action that happens in the brain. And then they promote insulin secretion, but a glucose-dependent insulin secretion. So if your glucose
levels are high... And this is only in people who can make insulin still. So someone with type 1 who has no beta cell function, you wouldn't see that.
So, basically, yes. Quite a lot of type 1s, for some or other reason, still do have a little bit of residual beta cell function. And very often you do see that it actually does enhance a little bit more. But yeah. It also suppresses the glucagon. So in between meals, you're not getting that glucagon surge. So it's really good at stopping those postprandial glucose spikes, decreasing insulin doses that are required. And then it also slows down your gastric emptying. So in other words, your stomach empties itself slower. So you digest the food better, you can absorb the nutrients from the food better, and you just feel fuller for longer. So it really does help those postprandial, post-meal glucose spikes, and then obviously helps with the weight management as well.
Wow. It has a multitude of benefits potentially for people with type 1, even if it doesn't help much with the insulin production. You got slower digestion, you get a sense of fullness, satiety, early on when you start eating. It prevents the glucagon production that happens inappropriately sometimes after we eat, because protein intake causes glucagon production, and that can make the sugars spike even more after meals. So it sounds like it could offer a lot of benefits for people with type 1. Not to mention over time the gradual weight loss that occurs.
Absolutely.
What are some of the drawbacks to using a GLP-1?
So I think the biggest drawback is, again, a misconception that a GLP-1 is insulin because they're both injections. And I've often heard people talking about my new insulin that they're taking. It's completely not insulin. And if you understand that people with type 1 diabetes require insulin, it's not a replacement for insulin. So I think that's the biggest thing to just drive home, and it's certainly not a replacement. The other problem is that it can still cause hypoglycemia if you don't adjust the insulin. So because it's making you a little bit more insulin sensitive and enhancing the insulin secretion, very often we find that people do need to reduce their insulin doses. And if you're not doing that, then you can obviously get hypoglycemia.
Yeah, if you get hypoglycemic and overtreat them like I do, the weight's not going to come off.
Absolutely. You're still packing on the calories.
Yeah. I still use my lows as an opportunity to just devour mass quantities. I really have to work on that.
Just one more thing on the GLP-1s. I think one of the main benefits in type 2 diabetes is that they offer some cardiovascular protection in type 2 diabetes, which is obviously a massive problem in type 2 diabetes. Mm-hmm. But the trials haven't yet been published on whether you still get that cardiovascular protection in type 1 diabetes. That hasn't yet been proven. Mm-hmm. I suppose it stands to reason that they would, but it hasn't yet been proven.
Now, is that cardiovascular benefit, is that dependent on one losing weight, or would it happen even if somebody didn't lose weight with those drugs?
So in type 2 diabetes, it's not dependent on the weight. It's independent of the weight loss and of the HbA1c. But that's what we don't know in type 1 diabetes.
Okay. It seems to reason that it would probably apply. We're human beings. It seems like it would work in both populations. Yeah. And then the third class of drugs are called SGLT2 inhibitors. Now, these have been out longer even than the GLP-1s. And I remember when these first came out, and I gave it a try. It's an oral medication. Why not? And it brought me back to the days when I was first diagnosed with diabetes, where I was just peeing my brains out because my sugars were high all the time. And now all of a sudden, even with blood sugars that were in a decent range, I was still peeing my brains out. So tell us about the SGLT2 inhibitors and what they do.
That's exactly how they work. They basically just make you pee out all the glucose that you don't need. And so they act on the kidneys, they act on the efferent arteriole, and they pull out all the excess glucose into the kidneys. So immediately you can see what the problem is going to be is that you've now got a bladder full of glucose. And because you're pulling out all that glucose and from the kidneys, your urine's going through into the bladder, infections, bugs, glucose. So all your urinary infections, sexually transmitted infections, that risk is increased if in someone taking an SGLT2 inhibitor. The other problem is that in type 1 diabetes, you often get, well, not often, but you can get what's called a euglycemic diabetic ketoacidosis. So in other words, you're getting a ketotic state happening at a normal sugar level because of the way in which the drug is pulling sugar out of the kidneys. And so you've got to be really careful of monitoring your ketones and alerting patients who are on an SGLT2 inhibitor that they need to still think about a DKA even at a normal glucose level.
What are some things the user can do to prevent the ketotic state when they're using these drugs?
So the main one is hydration. So it's just drinking copious amounts of water and making sure that you void the bladder on a regular basis so that you're not sitting there with a full bladder full of sugary urine waiting to get an infection. And to be quite honest, if I give that information to all my patients, and I've had very few having infections, I've heard from colleagues who perhaps don't give that same sort of information out, that they have a problem with patients coming back with recurrent UTIs. But I think it's a very simple message to give to patients. And if you give the message, people are generally more aware of it.
But I imagine that users have to be conscious to be consuming carbohydrates as well, because if they're urinating glucose away, it's taking away from the energy their body needs. So people who want to follow low carb diets are probably not great candidates for use of these.
Absolutely.
Okay. Any other benefits that are seen with the SGLT2 inhibitors?
Yeah, so I mean, they have showed, there are trials that show modest improvements in glucose reduction, weight loss, a decrease in the insulin doses. But the risk, as I said, is that you've got to monitor it very carefully and select your patients very carefully.
How about kidney function? Now, one would think if it's causing the kidneys to secrete sugar, then it's going to be harmful to the kidneys. Is that the case?
So the interesting thing is you actually can take it down to quite low levels of kidney function. And it's actually often benefits the kidneys. Certainly in type 2 diabetes, I think in South Africa, we can use it to a GFR of 25. I think internationally, they've pushed it down to 20 or maybe even 15, I think. So it is safe to use it in those. Often you just want to reduce the dose at those very lower levels. But it is safe to use and it has benefits to the kidneys at that stage. So again, it's one of those drugs where it's not only helping the glucose, but it's assisting your complications and reducing the risk of the complications that we're looking out for in diabetes as well.
Okay. So let's take those three classes of meds and just kind of quickly summarize the biguanides, specifically metformin and metformin extended release. Who might be a good candidate potentially for using metformin?
So those are the ones that have got this double diagnosis of diabetes. People are overweight, sedentary lifestyles, family history, and it doesn't necessarily have to be a massively obese person. It can just be an overweight person. So that would be, and it's very safe, very simple to take. It's a single tablet that you take at night. So that would be that population. The SGLT.
Before you move ahead, we've actually found that patients who struggle with irregularities in their blood sugar overnight can sometimes benefit, because the overnight irregularities are due to the liver putting out large amounts of glucose, and the metformin can suppress that and keep things much more stable at night. So we found that to be an effective use for it.
Yep. SGLT2s, I think here the key is patient selection. You want to be really careful, and you want a very well-educated patient, not necessarily scholastically well-educated, but just diabetes well-educated and very informed about their diabetes, that you've told them about DKAs, you've told them about hydration and emptying their bladders and things like that.
And given that it does promote some weight loss as well, since you're urinating away glucose throughout the day and night.
And it's got blood pressure benefits and renal benefits as well.
Mm-hmm.
So that's the SGLT2s. And then the GLP-1s, am I allowed to say that would probably work for everybody?
You may.
But yeah, I mean, I really do like the GLP-1 class of drug because they are so multifactorial in the way that they're targeting the glucose to the hyperglycemia. It's happening at a brain level, it's happening at a kidney level, it's happening at a pancreatic level, it's happening at a gastric level. And yeah, so they're promoting satiety, they're slowing gastric emptying down, they're allowing you to absorb the food better, they're increasing insulin secretion, they're suppressing glucagon, they're suppressing those postprandial, post-meal spikes, they decreasing insulin doses and promoting weight loss as well.
So we got a lot of potential benefits from these. And if you discuss them with your physician, have an intelligent conversation about why you may want to try one or the other, see if your physician is receptive to it. They may have a specific reason that they may not want to prescribe it. I would say that if they have a good medical reason for it, you should take their advice. If their only reason for not prescribing it is, well, that would be off-label. What advice would you give somebody like that? Should they probably seek out another physician?
I think often physicians are afraid of using something off-label and perhaps afraid of using something in a patient population that they're not used to. And taking on that risk. But I think if you've got the knowledge and the information behind it and you have a decent conversation with your physician, I don't think that too many physicians these days, obviously the cost is a little bit prohibitive for some people as well, but I don't think too many physicians are completely against it.
Living with diabetes is scary. We've got, besides all the extra work we have to put into it, there's this constant fear of serious health problems that it can cause, as well as hypoglycemia that is staring us in the face all the time. If your physician isn't brave enough to take a little bit of a leap of faith that this med is going to help you out of their fear for their own personal well-being, I don't know. I would suggest seeing someone else. I know your perspective is a little different, being a physician yourself.
No, I mean, I'm comfortable prescribing it, so I don't mind it. I think it is a lot more work for the physician because you're having to adjust the insulin a lot more carefully, and there's not a lot of evidence to back you up. But absolutely, if the patient is willing to take on some of that risk and is well educated and happy to do that, I don't see a problem with it.
Okay. Well, thank you. The education is an important aspect of all this, and with all of our clients at Integrated Diabetes, we empower them. We teach them about their options, not just their insulin options or their pump options, et cetera, but we're teaching them about their medication options. And certainly if it's something that might benefit them, we'll discuss the pros, the cons, and with all three classes of drugs, the biguanides, the GLP-1s, and the SGLT2s, there are distinct advantages for people with type 1. But there are also some trade-offs in terms of other health risks, nausea, and also potential cost. Is getting insurance to cover them for someone with type 1 isn't always possible. Some cases it is, some cases it's not. But until you try, you don't really know for sure. But they're certainly worth considering. So I'd recommend everyone who's listening, if these medications are of interest to you, if you think it's something you might benefit from, talk to us. Reach out to your integrated diabetes clinician, or do some research on your own, and then be prepared to have an intelligent conversation with your physician, with your prescriber. Paula, thank you so much for taking time out of your very busy schedule. I know you got a lot going on with your kids.
No.
A lot of activities. You're on your way to see one of your kids in a show, right?
She's choreographed the dancing in a show. Yep.
What show?
Alice in Wonderland.
Alice in Wonderland. Love it. That should be a lot of fun. So let's get you on your way. Anyway, we'll have some links about this topic in the show notes if anybody would like to check those out. I'm Gary Scheiner, reminding all of you to keep thinking like a pancreas.
Thanks for tuning in to Think Like a Pancreas, the podcast. If you enjoyed today's episode, don't forget to like, follow, or subscribe on your favorite podcast app. Think Like a Pancreas, the podcast, is brought to you by Integrated Diabetes Services, where experience meets expertise, passion meets compassion, and diabetes care is personal because we live it too. Our team of clinicians, all living with type 1 diabetes, understands the challenges firsthand. We're here to help no matter where you are in the world. From glucose management to self-care strategies, the latest tech, sports and exercise, weight loss, type 1 pregnancy, and emotional well-being, we've got you covered. We offer consultations in English and Spanish via phone, video chat, email, and text. Want to learn more? Visit integrateddiabetes.com or email info@integrateddiabetes.com to schedule a consultation. On behalf of Think Like a Pancreas, the podcast, I'm Gary Scheiner, wishing you a fantastic week ahead. And don't forget to think like a pancreas.